We are really, really excited to welcome back Dr. Melanie Sisti. She joined us earlier, is a psychiatrist at New York Presbyterian, and today she's going to talk to us about trauma. I just wanted to say sort of upfront that this presentation is generally, not going to be too sort of in depth in talking about particular traumas. But if you do find that you feel like off or that you feel triggered by anything that's being talked about, do whatever you need to do to make sure that you're taking care of yourself. As a heads up on that.
My name is Melanie Sisti. I'm a psychiatrist, which is a medical doctor who takes care of people who are experiencing mental health issues. That includes the ability to prescribe medications. And I work in HIV psychiatry at Weill Cornell and New York Presbyterian. And I'm happy to be here today to speak a little bit about trauma, which is a broad topic. I'll be speaking specifically about emotional traumas, obviously, because of the kind of work I do. So just as an introduction, trauma is an emotional response to a deeply distressing or disturbing event. It can cause physical, emotional, and psychological harm that can last long after the event has occurred. So it's something that people carry with them afterwards. In terms of how we think about trauma in medicine, it really is something that became like an entity that was spoken about in medicine and thought of as a medical condition after World War I. That was a time when a new kind of war was being used. A lot of young men were going to war and experiencing trench warfare, where they saw just massive amounts of death and destruction, and would come back from the war with something that was at that time called shell shock. And that was the first sort of literature about these experiences that we see in modern medicine. It was used really to describe the psychological trauma that's experienced by soldiers after that war. The British War Office sort of recognized it officially as a medical condition a few years later. Later, there's a term PTSD, or post-traumatic stress disorder, which was used to describe the psychological trauma that they again started seeing in medicine after World War II. So that was in the 1930s. And then half a century later, the American Psychiatric Association actually then began to officially recognize PTSD as a mental disorder. So there definitely were many people who were symptomatic, but it took some time for that to really become in the domain, something that was firmly in the domain of American psychiatry. So just to sort of get a sense of what we're talking about when we're saying shell shock, there were soldiers sort of like in the trenches. They were really exposed to extreme conditions. Bombs were being thrown into the area, so they would see friends and peers dying or experiencing dismemberment, and they themselves were fearful of loss of life or limbs. So afterwards, they'd come back from a war, and these were men who were sort of in their prime. They were young men, and sort of, I think, stereotypically people that were considered very tough, and they were experiencing symptoms of psychological trauma like nightmares, flashbacks, and anxiety. And really, many of them struggled to reintegrate into society. At that time, medical treatments included rest, massage, and electric shock therapy. The results of that were probably variable depending on which of the three were being used. So the American Psychiatric Association defines PTSD as a mental health condition that's triggered by a life-threatening event. And it can include sort of like symptoms in different domains. And you'll see here, veteran again, which was previously like sort of the stereotypical PTSD patient that we would think of. So those different domains of PTSD would be things like re-experiencing symptoms. So that's things like flashbacks, a lot of times in like movies and TV, you'll see somebody like waking from a nightmare that's related to a trauma that they've experienced. It can also happen during the day. People can experience a flashback during waking hours and just really feel like they're right back there in that traumatic situation. What do we do when something's traumatic to us? We stay away from it. So avoidance symptoms are another part of that. So just avoiding the thoughts and feelings. Going back to that sort of war example, a lot of times people would come back from war. I know even myself growing up, there were Vietnam War veterans that were my parents' age, and we all knew that they had experienced that war. They would not speak about it. It was just sort of an area to know. It was like an untouchable sort of topic. So that's an avoidance symptom. And then just generally avoiding places or any activities that could remind a person of those events. Negative changes in thinking and mood. That can be like difficulty remembering the details of a traumatic event. Sometimes people will have a terribly traumatic event and then need to recount sort of what that experience was for them. And they have just big blanks in terms of what they're able to recall. And that's because the mind sort of dissociates and turns away from that as a protective thing. That can also include things like negative thoughts about oneself or the world, that the world is a dangerous or a bad place, or that a person doesn't have control over the dangers of the world, that they've failed themselves in some way, or they're guilty for it. Unfortunately, sometimes we do hear examples of people who've experienced trauma, and it's sort of, there's always that question, well, what did they do to deserve it? Or why were they looking for trouble? That's sad because it's also a symptom that that person themselves can experience as part of PTSD. They'll lose interest in previously enjoyable activities, and then also have just changes in their physical and emotional reactions. So hypervigilance, jumpiness, angry outbursts, just feeling generally tense all the time. So when somebody has that sort of combination or constellation of different symptoms, together after a life-threatening event, that's something we consider PTSD. That kind of meets a diagnostic criteria for that. PTSD is a more chronic condition. There is something that we call acute stress disorder, which is basically the same symptoms of PTSD, but happens in the first month after a trauma. And it's important to sort of recognize those signs in a person because we want to try to help them manage the symptoms and improve to their baseline sort of previous level of functioning before it really takes a hold and becomes more of a chronic condition. After a month, we call it PTSD. The longer symptoms of PTSD go on, the more challenging they can be to change or improve. Now, we talked a lot about war, but actually the leading cause of PTSD in women is sexual assault. Domestic violence is also a leading cause of PTSD. Sexual assault, number one cause of PTSD, not just in women, but actually in all people. So, although the sort of stereotypical idea of what a PTSD patient looks like is a man in army fatigues or something, it's actually not that. And then stressful life events such as divorce, death of a loved one can also lead to severe psychological trauma and lead to symptoms of PTSD, and also make some people more susceptible to developing PTSD after another trauma. I think it can be helpful to sort of think about the way we talk about trauma in medicine versus the way we may talk about trauma just in general. So I have a kind of list here of things that we would consider qualifying experiences for a PTSD diagnosis. And that would be like death of a loved one, a natural disaster such as a hurricane, massive earthquake, serious injuries, severe car accidents, being diagnosed with a serious illness, and particularly a potentially life-threatening illness. Those are all things that are traumas that really make somebody feel vulnerable, as though they could die or their life is threatened. Everyday annoyances would be things like getting stuck in traffic, losing your keys, forgetting your wallet, having to wait. My son is 12. He's in middle school. He was traumatized because he forgot to bring his phone to school one day. So that's an example. He uses the term and I remind him that was probably very annoying, but I don't know as a psychiatrist that I would call that a trauma, but he's free to use the word, casually, however he wants. So then another thing that can come up a lot in sort of just everyday conversations is being triggered by something. What does it mean when somebody says that they're feeling triggered? When somebody has a diagnosis of PTSD, some of those things that they avoid are not avoidable. And when they experience them, they can feel triggered. And actually, that can trigger a flashback or trigger an extreme emotional reaction. So that's what we mean when we say trigger. When somebody's sort of casually saying they feel triggered, again, like by one of these annoyances, that's a little bit different in terms of the nuance than something that's a trigger for PTSD, which is going to result in some of the cardinal symptoms of PTSD. So trigger warnings would be just like warnings that can be helpful for somebody who really does have a diagnosis of PTSD or has, qualifying experiences and symptoms, because it can help people stay away from things that are going to become too overwhelming too quickly. So they're a little bit controversial. There's definitely conversations on like college campuses and stuff right now that by giving too much of a warning, it can kind of take away somebody's chance to actually start exposing themselves to everyday experiences in a healthy way and working through that. But on the other hand, PTSD symptoms can be so severe and are not terribly uncommon. So it can be a really sensitive way to help people navigate a world that can otherwise feel very scary or unsafe. So you'll certainly see more of that. And I've noticed and actually appreciated in like the evening news or something that sometimes they'll give a little bit of a warning before talking about things that are potentially damaging or troubling for people to hear if they're not prepared. And there is a sort of layering effect of trauma. So there's a sort of domino effect that somebody who's experienced multiple traumatic experiences in their lifetime can actually be a little bit more susceptible to experiencing PTSD and can just be re-traumatized more easily. A good example of a person that experiences the layering effects of trauma would be somebody who experienced childhood abuse. We definitely see higher rates of PTSD and PTSD symptoms in somebody who's already had trauma at a young age and then continues to experience that. So those are the symptoms. And I'll talk a little bit about treating PTSD. And like many things in psychiatry, there are treatment options that can include therapies and medications. And then there's also all that time that's spent outside of the sort of Western medical world and includes aspects of self-care for a person to feel more empowered in managing their symptoms. So the main types of trauma therapy are cognitive behavioral therapy, which is a kind of psychotherapy. I spoke a little bit about that last time when we talked about depression. It's a kind of psychotherapy that helps people identify and change their negative thinking and behavior patterns. So recognizing a sort of thought that's not helpful or is detrimental in a way, or noticing that it then leads to behavior such as the avoidance that we often see, and then reinforces some of that fragility that a person is experiencing with PTSD. There's also a newer therapy called EMDR, which stands for eye movement desensitization and reprocessing, which is a mouthful. I'll talk a little bit more about that as well. And then the sort of classic way of treating PTSD would be exposure therapy, which is a kind of therapy that helps people confront their fears in a sort of manageable, bite-sized way and in a safe environment. So exposure therapy, it's a type of cognitive behavioral therapy that's really specialized for trauma. It basically involves slowly exposing somebody to their source of trauma or anxiety in a secure and regulated environment. So helping them sort of confront and eventually overcome their fear, but bit by bit. So, that would include like for somebody who has, for example, like a severe car accident and is afraid to drive again. Some of that would just be first talking about it in a safe environment and then slowly starting to get into cars again and eventually be able to get behind the wheel again and then do even more challenging things like go over a bridge or maybe go over, drive in a situation that's fairly similar to the one that occurred during the trauma. Interestingly, more and more, this can also be done using virtual reality. And this is something that the VA medical system has actually really pioneered and done a lot of work with for people coming back from combat. They've developed virtual reality sort of situations that can help people create those environments where they're being slowly and cautiously re-exposed, because some traumas are very hard to otherwise recreate. And realistically, we know it's hard to really access a lot of therapies that are going to bring people back out into an environment where they're able to slowly start re-experiencing the source of their trauma. So that's an exciting sort of new frontier there. The other therapy that I mentioned is EMDR. So what happens during one of these sessions? This is a specialized sort of therapy that has been formulated for people who've experienced trauma. It involves sort of asking the patient to focus on the trauma memory, which they've already discussed and disclosed to the therapist, while sort of following the therapist's finger or a light with their eyes and using these sort of eye movements that are thought to sort of connect to the brain and maybe sort of get close to some memory centers, and then allows them to sort of reprocess those experiences and lay down new thoughts and emotions around that. And then sort of having conclusion sessions where they're able to have a new conversation with themselves about the trauma experience and the new sort of way that they're telling themselves their trauma story that can be empowering. It's a little complex, but very interesting. And this is an area where there's more expertise every year. I see more and more sort of EMDR therapy options becoming available. There are also some therapies that were fairly commonplace in terms of treating trauma that actually don't seem to be as effective. The biggest one would be psychological debriefing. So, if I were to give an example of that, if there's a patient in the emergency room after a trauma, the idea would be that you just take an inventory of everything that happened, just get them to tell the whole story, put it all out there, or even just, in my office, when somebody comes in for an initial evaluation and they're telling me about their symptoms, they may retell that story. However, if it's not done in a careful way, it's actually re-traumatizing for somebody to talk about their trauma. So that avoidance that's a symptom of PTSD is also something that in some ways is a protective mechanism. And the idea that just talking about trauma will help somebody process it and get past it was actually incorrect. That this is actually something that can really almost just reinforce the traumatic experience without adding a layer of resolution or additional skills. So that's something that we try to be really careful about when we're seeing patients who have experienced trauma, that we're not just going to ask them to retell all of the details of something awful that has happened without having any therapeutic sense of how we're going to help repackage that. It's like pulling a scab off and then sending somebody back out into the world. Other things that we think about with trauma is, how to build psychological resilience. So some people, as I said before, have these vulnerabilities, like the early childhood trauma experiences, that can just make them more vulnerable to developing PTSD or acute stress disorder. And then there are other people that can seem to take a lot on and just be very resilient. So there have been more and more psychological studies just looking at like, what's their secret? Like, how are these people able to experience the same trauma and just sort of be able to handle it in a healthy way? What was learned from that is that there are certain differences in these people and how they move through the world. One is that they tend to have good support systems, whether that's in place or something that they actually build for themselves. They do not feel as alone with their trauma because they aren't as alone managing it. There's also mindfulness and stress management techniques. People who prioritize self-care and engaging in enjoyable activities and staying engaged in those things after trauma tend to do better. They set realistic goals for themselves. Sometimes pushing too hard and really burning the candle at both ends can make somebody's stress levels go up so high and just add to that experience of being hypervigilant and anxious and having PTSD symptoms. Having and maintaining healthy boundaries, keeping dangerous people or unsafe people out of one's world to the extent that that's possible, staying present in the moment, being kind and forgiving to yourself, acknowledging, expressing, and validating the feelings that it can be okay to feel bad after something bad happens and to allow that instead of feeling like a need to reprimand oneself. Engaging in meaningful relationships and reframing situations, which is kind of like what we talked about back with the therapy, that sometimes it's not about necessarily deleting a memory, but reframing it and putting new layers on top of it that sort of retell the story in a more empowering way. So those are all ways to sort of build resilience. And it's so important because when people have chronic PTSD, they do have much, much higher rates of other psychiatric disorders, such as depression. That's for 50% of people with PTSD will also experience symptoms that qualify for a major depressive disorder. Anxiety is nearly as high. Substance abuse problems are very common after a traumatic event. And suicide rates, thoughts of suicide and actual attempts are much higher in the population of people who are traumatized. We also know that non-psychiatric conditions are more common in people who are living with chronic PTSD. So that includes things like cardiac issues, particularly higher rates of hypertension and cardiac arrests. That kind of makes sense when you think about how the body all works together, that when stress levels are high, the adrenaline levels are high, the heart is beating fast, it's always in that fight or flight mode. Long term, that's very hard on the body. Why to avoid alcohol in the aftermath of a trauma? So it seems so common that somebody experiences a traumatic event. The response is to have a drink, have a stiff drink, and sort of just calm the body down. But the problem is that that really gets in the way of the body's natural healing process. And it just then sets a person up for more physical and mental health problems. So gets in the way of sort of being able to process information properly and in a healthy way. And it can also increase symptoms of depression, guilt, shame, and gets in the way of healthy decision making. We all know that alcohol lowers inhibitions and that people tend to have more impulsive and less thought out smart decisions when they're drinking, either heavily or just regularly. It interferes with sleep. Even if a person thinks that they're sleeping when they drink, the quality of that sleep is not the same. Alcohol affects the sleep architecture. So although sometimes people with PTSD will drink to help fall asleep, the problem is that they wake up the next morning with a sleep deficit because the alcohol actually interfered with getting those sort of deeper levels of sleep that are restorative for the body and the mind. It can also lead to more substance use. It's very common once somebody is intoxicated with alcohol that if they're exposed to another drug that they might have held off from using, they'll be more susceptible to using it. And absolutely, alcohol heightens levels of anxiety and depression. Many times people will come to me and say they were feeling lousy, so they had a few drinks, and then the next day, it's almost like they had a rebound of the anxiety and depression. And that's very physiologic. That's what alcohol will do. It's almost like a mini withdrawal the next morning. So I did want to just give a couple of what to do sort of tips since sexual assault is so common and is the leading cause of PTSD. I just wanted to spend a few minutes talking about really practical things to do if you or a loved one experiences a sexual assault. The first thing would be to seek medical attention. It's important to get tested for any sort of exposures, but also the hospital. I know that emergency room experiences overall are generally not pleasant, but when it comes to special assaults, that's actually something that I think the emergency room and emergency medicine in general has been careful to modify. And now there are always social workers on who are automatically called after a sexual assault is reported for a patient. And they are able to meet privately with a patient. And these are people who are experienced in trauma counseling and are able to provide appropriate support that's not re traumatizing and can be very helpful in terms of providing resources and reassurance in a safe space in that situation. So that's in any hospital. They're going to have that service available, and it should automatically be triggered anytime a person comes in reporting that. It's also important to preserve any evidence of sexual assault, which is so challenging and not always what happens, understandably, but if there's a sexual assault, it's important to go straight to either the authorities or better yet, a hospital to preserve evidence, because washing and showering, anything like that can actually remove evidence. And it's important to have somebody to talk to, whoever it is, just somebody who's a trusted person or a support service that can actually give appropriate guidance in that situation. The easiest one would be the hotline that New York City has, which is NYC Well. And that's something that's available via text or phone call. It's available all hours of the day and night. and they are able to either provide the direct support or point people in the right direction after a traumatic event. There's also Safe Horizon, which is a confidential hotline for people who have experienced crime and abuse and intimate partner violence. For younger population, there's The Door, which provides confidential crisis counseling. And I think that that's very special also because of the lower age limit there, which can be really a vulnerable population. And we know right now that there's an adolescent mental health emergency in both the city and nationally. So that's a good resource to be aware of.
Can PTSD be cured? Do you talk about it in terms of being cured of it?
Yes. So there are positive prognostic sort of signs that somebody can really have a full resolution of their PTSD symptoms. And that tends to be, people who have natural resilience,
Mhm.
people who seek treatment early. There are some treatments that can even be given right after a trauma in the emergency room that can help reduce the likelihood of somebody developing PTSD. And then even for people who have acute or chronic PTSD, they can have a full resolution of symptoms,
Mhm.
although they can also be a little bit more vulnerable if they experience another trauma of having those symptoms come back. And I have seen that in patients who have had a traumatic event, had symptoms that would qualify as a diagnosis of PTSD, and had over a decade of
Mhm.
complete resolution of their symptoms, and then unfortunately have another very traumatic sort of event and the PTSD symptoms return and even can include flashbacks of the prior stuff that seemed to be sort of in the past and fixed. So all that to say, yes, it can be cured. It can go away completely. There are ways to make that more likely to happen. It can be more challenging the more chronic it becomes. But even for people who cannot have a full cure, and there is a subset of people who don't have a full resolution of symptoms, there are a lot of treatments available and medications available. It takes a little bit of trial and error, but there are many things available that can reduce the severity of the symptoms. And so it can still be meaningful, even if a cure isn't going to be on the table to reduce symptom severity. That's equally important.
Relationship between PTSD and MPD or multiple personality disorder, if there's a relationship there.
In psychiatry, we call that dissociative identity disorder. That's, what people are referring to though when they say multiple personality. There's symptom overlap. Somebody who has a history of trauma and is experiencing PTSD symptoms can often have dissociative symptoms. And somebody who's had trauma is actually more likely or at higher risk for having dissociative identity disorder. So again, it sort of requires a little bit of nuance about like, what's the main picture here? Like, are we dealing with a PTSD type picture or somebody who's mainly dissociating and not feeling very integrated? But there can be a tremendous amount of overlap there. When you think about dissociation, it's something the brain does sort of naturally during and after a trauma, and it's self-protective. It's a way of
Mhm.
sort of just going into a different plane mentally to get through a difficult experience or a difficult emotion. The problem, though, is that when that becomes overused, people can feel really fragmented. We want to be able to access all sort of parts of ourselves and not sort of dissociate into another place where we're really not able to sort of have an integrated sense of self and coping skills and identities. So again, there can be overlap, and we just sort of have to look at what the person's story is and why they're experiencing what they're experiencing and in what situations and in what way.
Underlines the importance of talking to a professional if you're experiencing symptoms, because they're going to have the diagnostic knowledge to explore that and make those differentiations.
Yeah, and if we can get a better sort of label for something, we can get a better sense of how to treat it in a way that's going to be most effective.
If you are someone with PTSD who is taking medication for it, like if medication is part of the treatment that is working for you, is that something that you end up taking your whole life or is that temporary?
It depends on the person. Some people take the medications and are in therapy and find that as they're improving, they're able to sort of cautiously reduce the doses of medication and get off of it. Other people, particularly people with more chronic and severe PTSD, find that really it's almost like a pathway that's so well worn in their brain that when they don't have the help of the medication, those symptoms start creeping back in pretty quickly. And attempts to get off the medication are just, not really worth it if they're feeling better on the medication long term. We always try though with medications to see, how
Yeah.
much is this really necessary long term? Because, most people don't want, understandably, to be on a medication forever if they don't have to be. So, usually after 6 months to 12 months, if somebody's having a first time event of
Yeah.
something, I think it's reasonable at that point to start cautiously trying to see what you can get away with reducing the medication.
How young people can be to be diagnosed with PTSD. So young children, is that a diagnosis that you see in young children?
So I don't treat children, so I am speaking outside of my scope of practice, but I'm not aware of any lower age limit. And certainly in child and adolescent psychiatry, PTSD is also a diagnosis and something that we can see.
You talked about this a little bit, but what could I do as a person to support someone who is struggling with PTSD without being sort of re-traumatizing, but being actually sort of helpful in that process?
Yeah, I think one thing is to first just provide the emotional support. It's not always necessary to hear all of the details. If somebody wants to share details, then I think that that's really helpful, but it helps a lot to sort of enter that conversation with open-ended questions like, I want to ask you this. Are you comfortable talking about this? And just creating a lot of space for a person to go at their own pace and only talk about what they really feel safe and comfortable talking about. Just providing the emotional support and check-ins. Always a good idea, though, to ask direct questions about safety. So whenever, somebody's experiencing psychological trauma or symptoms, it's a good idea to just say, are you feeling safe? Are you having thoughts you don't want to live? Because it's important to really take the temperature on that kind of a situation. And it doesn't require sort of asking nitty-gritty details that can be re-traumatizing. And finally, looking into resources and providing them to a person can be really helpful, because a lot of times when somebody's traumatized, as part of that avoidance, they don't want to sit down at a computer and start Googling resources and going through the web of difficult sort of in dead end sort of ideas of how to access help, which can be really challenging and something that somebody who's just been traumatized may not have the wherewithal to do. So a friend or a family member or loved one can sit down at the computer and actually start doing a little legwork and try to just give a couple of names or numbers or something to the person who could benefit from it.
Is there questions you would ask about hurting other people too?
Yeah, it's reasonable to ask that. As one of the symptoms that we were talking about before can be like angry outbursts and just sort of poor impulse control. So asking about that, asking about whether there are any weapons in the home, certainly a common conversation that we have with people like, maybe this isn't a good time for you to have, a gun or, and we certainly see that with people who were either in the service or NYPD who, commonly are going to have these kinds of weapons in the home. It's just important to say, nobody's taking it away forever, but it's important to take it away for now, because some things are just too easy to reach for in a crisis. We do the same thing with potentially fatal medications. So then also just asking about thoughts of violence is important. And sometimes family members can express, to friends and other family that a person is becoming more short-tempered or scary at home. And a lot of times that can also involve substance use as well.
I thought that was a really important point that you made about, the sort of addition of alcohol or substances to PTSD symptoms as feeling like something that can be alleviating, and then just sort of making those symptoms and those feelings accumulate over time. I thought that was a really good point.
It's a trick. It's deceptive.
Yeah.
It's deceptive. And certainly, I think it's also part of our culture that, oh, you had a day, why don't you have a drink,
Yeah.
But this is one of those situations where that can really end up coming back
Can catch up with you.
Catching up.